Hello, my name is Emil Malferrari. This is my first upload my video for the knee examination. So firstly, we would like the patient to lie on her back with the knee and the thighs exposed. I normally start by doing a general inspection of the patient. So firstly, I'm trying to look at both knees for any signs of swelling, change in color, scars from previous surgery, erythema, and any obvious deformity. I normally also would like to see the knee flexed to see if there's any patellar dislocation, normally to the lateral side. Next would be to having a feel or palpation. So normally I would feel with the back of my hand around the knee area for any warmth on both sides, for any obvious swelling, effusion around the knee joint. Specifically for effusions, I would normally perform two tests, which is first is the patellar tap for large effusions and the bulge test for the small effusions. So for big effusions, we do the patellar tap test. I would put my hand in the lower side of the quadriceps, push against the suprapatellar extension of the synovial joint, and then press downwards on the patella. Normally, if there's a big effusion, the patella sinks, and when it rises up, it will stop with a tap once it touches the condyles of the femur. The second test for effusions is the bulge sign. So same with the patellar tap, we compress the suprapatellar space, and I would run my fingers along this side to see if there is fluid wave on the other side, which means there is an effusion, and doing that on the other side as well. In this case, there is no effusion. Next would be to change the range of movement of both knee joint. So normal flexion would be 0 to 135 degrees and extension is 0 to 5 degrees. So we'll test this with flexion passively. That looks normal. It looks normal as well. In that case, there was a click and crepitation, sometimes indicates a chronic knee condition. We would test the range of movement here as well. Flexion 135, extension 5 degrees. Then next, what I would do is to palpate for any tenderness. So normally the knee would be flexed, thumbs pressing along the anterior joint line for any tenderness, and palpating around the attachments of the medial collateral ligament and the lateral collateral ligament. Doing that on the other side as well. Collateral ligaments, it's fine. Next test would be to test the integrity of the collateral ligaments. How I would do this normally is to put one hand on the thigh and one on the leg, and by applying opposite movements, this time I'm going to, with my right hand, pull the leg inwards, testing while this stabilizing to test for the medial collateral ligament, the other side for the lateral collateral ligament. Doing it on the other side as well. Any movement or laxity more than 10 degrees, they say, is abnormal and would probably indicate a tear or an injury of the collateral ligaments of the knee. Next test would be to test the cruciate ligaments. So testing for the anterior and posterior cruciate ligaments. What I normally do is put some weight on the foot, put my fingers here, okay, and trying to do the anterior or posterior drawer test. So pulling, pushing, pulling, pushing. Normally, if you feel that there is increased anterior movement or increased posterior movement, that would indicate a possible tear in the anterior posterior cruciate ligaments. Alternatively, we can do a Lachman test. We slightly flex the leg and then one hand holding here, just pulling and pushing back to see if there's increased laxity of the joint. Next test, in cases of history of repeated patellar dislocations, is the patellar apprehension test, pushing the patella to the side laterally, and then flexing the knee and looking at the patient to see an impending sign of dislocation. Lastly, I would like to ask the patient to lie on his abdomen, on her abdomen. Now this is a time to inspect the back of the knee as well for any signs of swelling like a Baker's cyst, or if it's a pulsatile mass, a popliteal aneurysm, or hard masses of any kind. Now this is also the ideal position for me to test the meniscus. Normally I normally do the Apley grinding test. So by flexing the knee 90 degrees, then moving it forward and backward while twisting the knee. Normally any clicking or any pain perceived by the patient would indicate a possible or likely meniscal tear. And lastly, I would then let the patient stand up. In this case, there's no one holding the camera, but having the patient stand looking at any valgus or varus deformity. And lastly, I end it with a test of function by having the patient walk forwards and backwards to see if there's any abnormality of the gait, especially movement along the knee joint. So this is my first video. Thank you.